thank you all. Thank you for the invitation, and also thank you all for staying so late. I'm an epidemiologist working at Hadassah Hebrew University School of Public Health, but I'm not going to talk about my research, but on this program that we at the school are leading. It's not about prediction, it's really real life use of electronic medical records. So when we are talking about quality of care, what do we talk about? So we are talking about the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Why do we want to measure quality? The basic reason, and also very intuitive, is that if we want to improve quality, we need to make some efforts to measure what we are doing. Nevertheless, I don't want us to overestimate the size of effect of healthcare in the health of individuals. So in this socio-ecological model of health, in these concentric circles, the more you are towards the center of these circles, the higher the impact on your health. So basically, the most important factors are your individual traits, the age, sex, hereditary factors, then we go farther to our social connections and so on. And then almost in the outmost circle, we have the healthcare services, which probably are not supposed to have much impact on our health status. Having said that, I hope I'll convince you that we in the program, by changing or helping modifying the quality of care supplied to Israeli citizens, had some effect on the population health in general. So the Institute of Medicine defined 6 pillars of quality of healthcare, or what are the aims of a healthcare. We want the healthcare to be effective, to be safe, to give timely services, to be patient-centered, to be efficient, so to avoid wasting waste, and to be equitable. To measure quality, we and almost all quality programs use quality indicators, and most programs are centered in hospital care, and that's why the definition here talks about the quality indicators in hospital care. The definition of quality indicators is that these are standardized evidence-based measures of healthcare quality that can be used with readily available data to measure and track clinical performance and outcomes. So following Avidis Donabedian started with talking about measuring quality of healthcare already in the 1960s, but programs that really actually measure quality of care using quality indicators started in the 1990s and to early 2000s, and one of these programs is the Israeli National Program. Just to touch bases for those of you who are not aware of, the healthcare system in Israel is acting under the National Health Insurance Law that was enacted in 1995, and it aims to provide health services on the principles of justice, equity, and solidarity, and to supply them with quality. And that's maybe the legislative basis to our program. We have this universal coverage for all citizens, and the health services in the community are provided by 4 health plans. The services are defined by the health basket, and one of the main sources of funding is the health tax. So our program, the National Program for Quality Indicators in Community Healthcare, or as some of us call it, KISH, has the mission to provide consumers, meaning the public, health professional and policymakers with information on the quality of primary healthcare in Israel. What we do is we provide population-based information to ensure that medical quality plays a role in decision-making. And in a sense, I think the program did a paradigm shift in the provision of healthcare in the community. It enables the evaluation of developments and changes in healthcare over time, the early identification of risk factors in the population and subpopulation, and we do routinely comparisons with other countries. We have the potential to increase efficiency and reduce costs. The characteristics of our program, there are 4 main characteristics that I'll talk about: the framework, population, data source, data collection, and Q&A. So the framework is the partnership, a voluntary partnership of all 4 health plans. They all have a voice in this program, and all of our decisions are consensual. Therefore, we have this national coverage. So the population, it's a population-based near complete coverage. The health plans provide healthcare to all citizens, except for, on one hand, prisoners, and on the other hand, soldiers. The data source is the electronic medical records, which include the physician visits, nurse records, hospital procedures, lab results, and pharmacy claims. We, in the program, produce the algorithms for data retrieval, so it will be standardized across all health plans. The data that we collect is aggregated, so it's not individual level. We have it stratified by sex, age, social class, and recently also geographically distribution. So when we develop indicators, we basically want to start with topics that are important and are relevant, that we have evidence for the indicator. We also look into other programs in the world. We want to be able to quantify. So maybe that's one of the limitations, is that we need all of our indicators are ratios. So we have a numerator and denominator. We have to be able to quantify them. Then we ask ourselves whether we have data in the electronic data of the health plans. Nevertheless, if we don't have available data, that's not a reason not to have this quality indicator. We develop specific fields in the computerized health records. And last is, of course, the implementation of quality indicators. So up until 2019, it has developed over the years. The program started in 2002, and there were many indicators and fields added, and some were abandoned. We measure healthcare in 9 fields, basically health promotion, cancer screening, child and adolescent health, elderly adults, respiratory disease, a little bit on cardiovascular health. Our flagship is diabetes. We have measurements in infectious disease, including antibiotics, and mental health. For the year 2020, because it was a very irregular year, following reports from the health plans themselves, and also what we started seeing in the media about the reduction in utilization of healthcare, such as here we see this major decrease in colonoscopies conducted in the community in the United States. We thought that for 2020 it wouldn't be reasonable to have the same measurements, because we don't think that that would really indicate about the quality of healthcare in Israel. But more, we were talking about healthcare utilization, trying to estimate what would be the potential implications of suspected changes in healthcare utilization. And for that, we selected a very small number of indicators, some old ones, some we developed specifically for this report, and we measured them on a monthly basis. So as an example, I just brought some measures for diabetes. So diabetes measurements were there from the beginning of the program. And they developed over the years. I won't talk about all the developments and additions and deletions and whatever we did there, but I'll just talk about the two very basic indicators. First, in order to have a denominator, we have the prevalence of diabetes among Israeli adults. So when the program started in 2002, about 4.7% of the adult population had diabetes. Over these years, this has increased twofold, but in recent years, since 2012, we have about, really we plateaued, which is a good news. We are around 9.7% of the adult population having diabetes. One of the indicators is the annual testing of hemoglobin A1C. So the guidelines for hemoglobin A1C testing is having at least twice a year. Nevertheless, the indicator that was implemented since 2002 is having at least once a year test, and therefore what we have here is the proportion of patients with diabetes that were tested at least once in a calendar year for hemoglobin A1C. And this has really already when the program started in 2002, the rate was really high. It was about 83%. And it has increased, but it's not, it's not a dramatic increase. It's not what we saw with colonoscopies, for example. So, but it has increased, and it plateaued on about 90%. And in 2020, we see this a slight decrease, but it's kind of an unusual decrease of almost 3%. And if we look at the numbers of numerators and denominators, the major reason for this change, the numerators stayed about the same, but the denominators increased. As we see almost every year in numbers, we see this increase in the number of patients with diabetes. When we look into this kind of new measurement that we looked into the monthly hemoglobin A1C tests, so first of all, we were happy to see that per patient with diabetes, there are on average 2 tests a year, which is about what is recommended by the guidelines. And if we compare 2019 to 2020, we can see in 2019 is in gray, that there are not many variations throughout the year. However, if we look in 2020, we see these variations, this decrease, I think, which is catching the eye in March and April 2020, some kind of catch-up in June, and then maybe a slight decrease in September. Just to remind us all, for if there is anyone who managed to forget, that lockdowns were in Israel in March, April. Then we had another lockdown in September, October. However, the lockdown in September, October did not manifest itself in a decrease in hemoglobin A1C testing. And if we look into like month-by-month change, comparing 2020 with 2019, we see this decrease almost like we saw in the colonoscopies in the United States of about 56% in April. And then overall, throughout the year, it there was a catch-up, so the total decrease was by almost 6%. What we see here is when we stratify these decreases by social class, so social class 1 is the lowest one, and social class 4 is the highest one, and we see that there was a variability in these changes, the monthly changes by social class, so the decreases were more deeper among those of social class 1, but then the catch-up was also higher in social class 1. And overall, when we look into the right-hand side bars, we can see that maybe the outlier here is the highest social class, where you don't see almost any change comparing 2020 and 2019. Then the next kind of really one that you would like to know about is the controlled and uncontrolled hemoglobin A1C. So for hemoglobin A1C, there are target levels depending on the duration of disease, depending on the age. So what we call a controlled diabetes is when we have hemoglobin A1C under 7 or 8% or under. And what we call uncontrolled hemoglobin A1C, and this does not depend on age or whatever, is having hemoglobin A1C above 9%. And throughout the years, what we saw really is this increase in the good control of diabetes and the huge decrease in uncontrolled diabetes. So when we started in 2002, it was 21% of patients with diabetes who had been tested had uncontrolled diabetes. And this is really steadily decreasing throughout the years. And just to show what happened in 2020, it continued decreasing from 9% to 8.8%. If we looked into the monthly variation in rate of controlled diabetes, there was practically no variation, and 2020 was lower than 2019, which were good news. We somehow, physicians and the health plans representatives expected to see a huge increase in uncontrolled diabetes in 2020. The program allows us to look into subpopulations. So one of the ways we can, one stratification that we're doing is by age, and if we look into the uncontrolled diabetes in 2019 is in blue, 2020 in orange, and generally we said that on an annual basis we decreased from 9% to 8.8%. We can see that the decrease was almost only in the younger patients, and we know that the young patients are typically have higher rates of uncontrolled diabetes, whereas among the older patients, we do not see any change in uncontrolled diabetes. When we look in stratification by social class of the uncontrolled diabetes, so we know that there are gaps. We know that the patients of the lowest social class have much higher rates of uncontrolled diabetes, and these gaps started closing throughout the years, but we see that in 2020 they kind of widened again, having about 3 times the rates of uncontrolled diabetes among those of social class 1 compared to the highest social class. So we see an increase of rate in uncontrolled diabetes among the lowest class and a decrease in the highest class. Okay, just wanted to show some impact on health. So, yeah, okay. So just to show, these are the diabetes attributed, the mortality from diabetes on a national level. We have in red among Arabs that we know they have higher rates, higher prevalence rates of diabetes, and in the gray we have the Jews, and we see a change in the trends of a decrease of mortality from diabetes. This is on an ecological level. We have many other examples to show that there was a change in the health status of the Israeli population. However, we also conducted a study on an individual level, on a national basis. These are the results of time-dependent Cox models, and we see the hazard ratio for all-cause mortality among patients with diabetes according to our quality measures, whether they achieved the target goal or whether they were unmeasured. So we see for uncontrolled diabetes, for example, we see a hazard ratio of 1.4, and for those who were not tested, we had a hazard ratio of 1.5. We have problems with our data. We lack lots of data in the EMRs, and I think these were touched. These were mentioned before, and I think we need to work towards improving the EMRs. And just to conclude, the high-quality EMRs, together with the unique ID numbers, allow the implementation of a national quality indicators program. Israel is the only one that has this program based on EMRs. And the quality of care improved since the establishment of our program, and I think it's also reflected in improved public health, and I'll skip the rest. And I want to thank all of my partners, and thank you for your listening.